Hello, welcome to our live Q&A sessions. My name is Matt Ithurbun, and I'm the organizer of ACL Study Day. We recently launched a big online course with some amazing educators, and I've asked them to join me today to answer some questions about their topics. What we have today are 3 sessions in the morning with almost all of our presenters. Our first session starts now, and today I'm joined by Dr. Elizabeth Wellsandt, Dr. Matt Ithurbun. I'm joined by Stephen LaPlante, and we're hoping that Dr. Dustin Loveland can join us soon. So before we get into questions, I appreciate all of you guys being here. Before we get into questions, would you mind each just taking a second and talking about who you are and what your work looks like? Liz, you want to start us off?
Yeah, you bet. Good morning, everyone. My name is Liz Wellsandt. I'm an assistant professor in the Division of Physical Therapy Education at the University of Nebraska Medical Center in Omaha. And I direct our clinical movement analysis lab, which is a biomechanics and physical functioning space. I primarily am research and teaching roles, and my research is primarily focused on early development of OA after ACL injuries. Matt, I'll toss it to you.
Hey everybody, my name is Matt Ithurbun. I am a faculty member at the University of Alabama at Birmingham, UAB, Blazers, not the football campus, which I have to clarify a lot, it seems. So I have a background in sports medicine clinical practice, and my research primarily focuses on improving rehab and outcomes for people with hip and knee injuries, and a lot of it to date has been in those with ACL reconstruction.
Hey guys, my name is Stephen LaPlante. I'm the lead therapist here at Children's Health Andrews Institute in Plano, Texas. Been a clinician for about 15 years, with most of my focus being on ACL rehab. Starting to dabble a little bit into some research projects. We've got a couple things coming up this year, but was able to work with Dr. Andrews for 10 years in Florida. Came out to Plano, took all that knowledge and brought it here. Been speaking about ACL rehab for almost 15 years now.
All right, we've got a good bunch here. All right, well, we can get right into some of the questions. So the first question I have is a clinical one. So could you comment on how much hyperextension to restore in an athlete after ACL reconstruction? So like if their unaffected limb has 10 degrees of hyperextension, is that the goal for the surgical limb?
Yeah, I think so. I think eventually we need to get that symmetrical. It may not be something that we aggressively go after right away. There's been some discussion that some of our females may not need to get back to that hyperextension as quickly, but I think it creates asymmetries in general. And then, you know, it may take 6 to 8 weeks to get it all back, but I think that I would try to go after getting symmetrical to the other side.
Okay. So keeping it clinical here. So I was noticing your tracking grid doesn't have hot tests until 7 to 9 months. You have lots of other great measures, but why not start tracking those earlier?
Yeah, I mean, you can. I would say probably about a year ago, we were doing hop testing at 6 months post-op, but it really comes down to like risk and reward. So we know from a lot of our studies that we still have significant quadriceps deficits at 5, 6, 7 months, even close to 9. My question and my thing is, what are you getting out of that other than maybe some baseline scoring saying that, you know, we know the athlete's LSI from a hop is whatever percentage, and, you know, we want to get to this. I would question that they have the capacity to use a knee dominant pattern and not just use their hip. So it's not that you can't do it. It's just, is it the best idea? And does it matter if you waited a little bit longer to do it, knowing that you have other measures that you can use to kind of track progress? I don't know, Matt, how you feel about that.
Yeah, I agree. I think it depends on what you're trying to measure. If a hop test is being used in place as a correlate of quad strength, and you have a better way to measure quad strength, then you should measure quad strength. I think if the goal is to look at, from a performance standpoint, then I think it makes sense to use. So I think to Stephen's point, you know, if your athlete still has underlying quadriceps deficits, the likelihood that they're going to use their quads as the power generator in a single leg hop test is low. And likely they're going to be movement adaptations or compensations that are going to mask I think it comes down to what the goal of doing hop tests is and what you're trying to measure, essentially.
Yeah, and I think too, like, prove to me too that your athlete has that strength. Like, if we're going to do some type of strength testing, whether it's a biodex or whether kind of like I think it was Jacob was talking about doing some dynamometer testing. Like, prove to me they have at least 80% quadriceps function before you're doing that. I mean, I'm not going to have my kids tear their ACL doing a hop test in my clinic. That's not good for business, and it's probably not good for the parents either or that kid. So.
Yeah, and I think, to the point of movement adaptation and asymmetries too, if they do have that underlying quad strength deficit, less than 80%, less than 90% even, they are going to adapt to achieve performance. Like, our athletes are good movement compensators. They will figure out a way to perform probably even similarly to their uninjured limb, but likely not in an optimal way. And so I think having that baseline of strength and muscle performance, while at the same time using unique approaches to retrain movement patterns, loading the knee and so forth is important.
Yeah, we use the same 80% cutoff before we do any single-legged hopping. And I think another risk of doing it too early is, if anything, if they're going to compensate and they might meet 90% criteria for that much earlier than where their quad strength is or where they're ready to go back to sport. Another risk is that the athlete or the patient has an inflated sense of where they're at, and they're going to go out and start doing more than they should be, or they're going to think they are ready to go back. And I think it risks losing them and risk losing some of their buy-in with the rest of their rehab as well.
Okay, let's. We'll have a question here about isokinetic testing. What rep scheme are you using? And are you looking at peak force for peak torque for return to sport decision making, or using work or an average of peak torque? Maybe we could get a comment on the clinical applications and then what the research says about what to look at.
Stephen, you want to start?
Yeah. So we do 180 and 300 at 4 months post-op, and then we kick it into the 60 degrees at 6 months post-op. And that's just, I mean, if you've ever done a biodex test, like 60 degrees is pretty stressful. Like, it's pretty hard to do. Granted, it's definitely going to measure probably more of your power, and that's what we want to do later on. But I just don't think we've loaded them appropriately. I mean, I've done probably over 500 biodex tests in my career. Most of those people, if you did it early, you could, but you're going to have a 35 to 50% deficit anyways. You're never going to see much better than that because you just haven't loaded them appropriately to get that kind of strength or that type 2 muscle fiber development. And maybe with some of our BFR stuff, we can maybe see some of those changes happening earlier. But like, as of right now, we don't really test until I think it's like 6 months for 60 degrees. And so at 60 degrees, it's 5 reps, 180, it's 10, and then 300, it's 15. So that's more of your muscular endurance stuff. And we look at peak torque. We are also looking at, I don't know if you guys have ever seen the isokinetic at the bottom. You have a kind of a body weight ratio. And so you'll kind of get like an average. So there's like normative values for boys and girls. And so you'll kind of be able to compare the left and the right, the injured versus non-injured to like the normative stuff. You can use that too and say, like, you may have an athlete that tests out at 6 months and they have a 90%, like, or 10% deficit, however you want to look at it. But they're equally weak on each side, right? So we see that quite a bit, even on some of our female athletes. Like, their hamstrings look great, they're symmetrically, but they're symmetrically weak. So you have to kind of take all the pieces of the puzzle in this biodex testing and not just look at the graphical data as far as that people.
Yeah, that's great. And I think in terms of testing and, specific to the question about rep scheme, I think what we do is pretty similar to what Stephen just described. I think some additional things to consider with regard to mode of testing and speed. Thinking a little bit about high speed versus low speed isokinetics. One thing that low speed and isometric testing gives you is higher torque, or a better understanding of force production capacity in the quads, primarily being the focus. And what we've tended to see is that at higher speeds, this kind of more endurance focused rep scheme and construct, that we tend to see less asymmetry there than we do at lower speeds where they're producing higher amounts of force or torque. I think the trade-off there is that, as Stephen described, 60 degrees per second or isometric does put a lot of load on the patellofemoral joint in particular. So depending on how weak or strong you think they are and how far out from surgery they are, if they're having patellofemoral symptoms, which some of these patients tend to struggle with sometimes, that I think is a part of the decision-making scheme for strength testing too. But early isometric strength testing is a great place to start, and it doesn't have to be done in an isokinetic dynamometer either. We, I think, through this course have talked about some other modes and approaches to strength testing, which are a great place to start.
So would the speed with which you're testing, would that maybe change based on the sport the athlete's going back to, the demands of their, of their lower extremity musculature?
For us, no. We test everybody the same. We don't really differentiate that too much. I mean, like Matt mentioned, if you've got a kid that's been fighting patellofemoral stuff, like, you may want to make the consideration not to do those slower speeds for a little while longer. Matt, I don't know if you've ever had it happen, but we've had a handful of kids that were doing great, and then we, did the isokinetic test at 16 weeks, and they kind of got irritated, to some extent, whether it was quads or hamstrings. And I mean, it's a lot of work. Like, if you've never done that test, like, it's pretty intense, especially if you do it at the end of the week after they've had like a lot of sessions. Like, that's another thing too to think about from when you do it. Like, I always try to test early in the week when they're fresh. I don't like to test when they've had like a long week of either rehab or performance and they're kind of fatigued out. Now, maybe that's something we want to do later on. We talk about fatigue protocols, but like in those earlier phases of testing, I'm not a big fan of like doing it when they're really tired.
Yeah. But I think what we should be cautious about is not taking Stephen's point about some of this clinical decision-making around, irritation of patellofemoral pain as a reason not to test strength. Yeah. We should test strength however you can, and with whatever approach you can. It should be a serial measure that informs how you target and adjust and modify your rehab and make decisions with regard to phase progression and moving toward, return to sport phase, for sure. But of course, as with all the patients we see, there is, there needs to be individualized decision-making there.
But I think at some point you have to have either an isometric test, whether that's clinically using a handheld or crane scale, if that's what you have access to, or on a isokinetic dynamometer, or you need to do isokinetics at a lower speed, like 60 degrees at some point before you clear them. Because if you're only doing high speed, you're going to miss their underlying baseline strength capacity. So at some point that has to be included.
Okay. All right. Well, I just want to do a reminder to anyone who's just joining us. Please feel free to add questions. You can add them to the chat, or you can go on Slido and add them there. One just showed up. How quickly do you feel comfortable measuring max static quad and hamstring, assuming a hamstring autograft strength via dynamometer test? How soon after that surgery? What do you think, Stephen?
Say that one more time, man. Sorry, I'm trying to get my mic adjusted a little bit. I apologize if y'all can't hear me very well.
You're coming in clear now. So how quickly do you feel comfortable measuring max static quad and hamstring, assuming a hamstring autograft strength, like with a dynamometer test?
Okay, so hamstring autograft measuring. Are we talking about just like isometric or just like max strength, like isokinetic?
Yeah, probably an isometric, knee extension, knee flexion. What do you?
Yeah, I think
how
it's
soon are you doing that?
Yeah, 8 weeks.
8 weeks.
Yeah.
Okay. Simple. Love it.
Yeah, I would say 8 weeks for the hamstrings, just because if here we're thinking about hamstring autograft, allowing for graft site morbidity, healing and whatnot, is certainly something to consider for hamstring testing. quads, they may be ready to be tested earlier than that.
Okay. All right. Okay. I have a cartilage question here. So what are some of the clinical takeaways from your recent publication on gait mechanics and T2 relaxation times at 1 month after ACL reconstruction, Liz?
Yeah, that sounds like it's directed towards me. I think the takeaway is that the two are intimately linked. Like, mechanical loading of the cartilage is related to the structural quality and integrity of that cartilage. I hope we have some more answers because we are collecting some longitudinal postoperative data. So it's really hard to answer that question just within that cross-sectional analysis we did preoperatively. Whether or not that loading is kind of leading to the changes in cartilage, or whether the trauma to the cartilage from the time of injury is changing how they mechanically load it and possibly offload it to protect it. And maybe a combination of that is likely going on. So we don't know what direction that's leading, but I think it demonstrates how important loading is to what we're measuring, at least with quantitative MRI measures. And so I think it just points, we know that resolving symmetry, whether it be with strength or whether it be with mechanics, is important for many different outcomes, but I think it's going to be critical as we learn more in terms of cartilage health. The cartilage matrix is a connective tissue, just like tendon, just like ligament. It has collagen that is going to need to be loaded to maintain strength or to improve strength within that collagen network. And so I think it needs to be loaded to stay healthy. And we're going to learn more and more about that, even with an injured knee. But I think that this whole discussion about restoring symmetrical movement patterns is incredibly important for long-term joint health.
Is healthy loading or optimal loading known? Is that something that we can say that this is how much cartilage needs at this point?
Not after an ACL injury, no. I mean, I think we need to think about cartilage loading just like we think about loading of any other tissue. Like, it needs to be progressive, right? It needs to ramp up over time, just like we load the quad, just like we load tendons and tendinopathy. I think we probably are going to be needing to follow those same principles and think about it at that level in terms of cartilage. We're doing a lot of work really looking at both mechanically, how they're walking and loading during single steps, but we're also tracking a lot of objective physical activity and thinking about the repetitive loading over an entire day and how those two things might work together and give us a better idea of how much total loading the cartilage is seeing. I don't think we, in the early postoperative stages, probably as a profession, do a great job of thinking about how to progressively load them repetitively before they start running at 3 or 4 or even 6 months down the road. And so there might be simpler ways, thinking about stationary bikes or walking programs or something, to be able to load the cartilage enough in addition to restoring normal movement patterns. So more to come. I hope I have better answers in a couple of years, but I think we have a lot to learn in terms of what we can do early to kind of preserve that cartilage health down the road.
And how, maybe this is a good question for you, Stephen. How are you talking to your athletes maybe in the prehab phase about this kind of thing, about maybe cartilage health, arthritis down the line, and maximizing sort of the early postoperative phase to help put yourself in the best position in the long run?
Yeah, it's a huge piece of that preoperative visit, and even the postoperative day 1, day 2. And I literally had the conversation at least 5 times last week with parents that, and it really, in my population, it's such a youth population, so I have to deal with parents as much as anything. And there's always this, how soon are they going to get back? The coaches wanting to know, and you kind of explain to the parent, like, drop all the research that's out there and say, we know that we should wait, at least 9 months. We've got all these studies, 50% reduction in injury risk. And then we start talking about cartilage, and I'm like, your kid's 13 years old. We know there's going to be some arthritis setting in at some point in time in the next 5 to 7 years. If we can minimize that, I kind of use it as my running. Like, I'm not a big fan of running too early, too quick. I think there's other things I'd rather work on, but I kind of use that as a way to kind of explain, don't push your limits, especially at this age. You've got lots of time to kind of rehab and get better. But yeah, that's a huge piece. Like I'm dropping all kinds of stats on these parents, and it's kind of eye-opening because they're getting information from other people on their team that so-and-so got back at 6 months. Their doctor cleared them at 6 months. Why can't my kid get back? You have to kind of have that stuff, that ammunition almost in your pack to say, hey, like, this is not why we don't push for this 6 months return. We're going to push back a little bit. I have a kid right now. He's had 2 ACLs and a meniscus, and he's a senior. Just had another little, I'll call it a knee contusion. So they went ahead and did another MRI. And I mean, the amount of arthritis on his lateral side, like, it's pretty bad. And the kid's 18 years old. So it's there. He had his first ACL at 13, his second one at 15. Has been pretty healthy since then. But yeah, I mean, we see it.
Yeah, young people with old knees, right?
Yeah.
Yeah. You don't want to be 30 with a knee that looks like you're 80 or 90 years old. And that's unfortunately what's down the road for some of these kids. And I think what's also eye-opening with that preoperative data that we just published is that that there are pretty significant changes in some of these individuals within that first month. And I think it just points to the importance of even preoperatively trying to restore as much normal movement and quad strength as important as possible, because otherwise they're going to carry that into the early months post-operatively if they're going into surgery like that. And we just lose so much time of loading the knee in a somewhat normal way. So I think it points to even more the importance of doing the best we can preoperatively to set them up a little bit better post-operatively.
Yeah. Well, that leads me into a next question, which is there, I mean, do you see value in doing the 5 weeks, twice a week training program preoperatively once the knee has gone quiet and 70% limb symmetry index or quad strength? I mean, that's sort of what I think some of the research that I've read has been.
Yeah, there's a ton of value in it. I see it all the time. It's just, can we actually do it? You take a kid that has a 20 visit max on this insurance, you tell me how you're going to fix that. Now, if you want to be creative with it, fee for services stuff, and there's all kinds of ways around it. But yeah, I'm not a big fan of getting a knee that's 1 or 2 weeks out from injury that hasn't had prehab, because I know I've got a lot of work in my hands to get that thing back to normal. I have a kid right now, took 4 months off. There's some insurance things. He tore it in October, didn't have surgery until January. If you looked at this kid, I think he's almost 14 weeks out. I'm going to test him, but I would guarantee he's probably close to 90% LSI already. I call him my little unicorn because I've never seen someone like this good out. I've seen some pro athletes like that, but not from like a high school kid. But he wasn't in a rush. His senior season, he was over. So he just took time. He went to the gym. I mean, this kid is phenomenal. So yeah, there's definitely value in some of that preoperative stuff. But at least get the knee fully straight, get as close to full flexion, pretty much no swelling, normal gait pattern. I tell the kid, your knee should feel like you haven't really had any issue with it before you go into surgery. But I don't always have that control. Like, I wish Dustin was on, but sometimes the docs kind of make that pull, like, we're going to go ahead and do it anyways, and we don't always have that control of how long they get to do preoperative rehab.
Yeah. When you do have a nice long prehab program, are you gathering isokinetic data? And then if so, are you using that as your baseline down the road?
I wish I could do it every time, man. I wish every patient that came in the door, I could get isokinetic data on, because, we've seen studies that say that we're not bar to bar. Like, when we test, like, we're testing at a lower level on their good leg or their non-injured leg. So yeah, I love having that data. I would love to collect it on every patient. We're trying to get that to be part of our protocol, honestly, here at the Andrews Institute, that every post-op patient comes in and at least gets a Biodex test.
Liz, you can probably chime in on that.
Yeah.
Liz published one of those papers.
Yeah, I mean, I think for a set of not everyone is going to be stronger on the uninvolved side preoperatively. Some of them probably have a little bit of anxiousness doing that type of test, even on their uninvolved side, or what be it. And I think it matters, are you doing it within 2 weeks of injury? Or are you doing it right before surgery when they're feeling better in general? And how might that change it? But we track that preoperatively all the way through return to sport. And there's definitely a group of patients that are stronger on their uninvolved side preoperatively. Not everybody, but some. And so I think it is really important to track, because we know the contralateral limb has a high risk of seeing another injury too. So we track it preoperatively, both sides, and use that to make sure that if they are stronger preoperatively, that we're using that as our goal at return to sport versus, they're wherever they're at on their contralateral side postoperatively.
Okay, another question just popped in. Can you speak to the role of subchondral bone contusions and the relationship with to restoring knee range of motion, strength, gait, and OA risk?
I can jump in regards to OA risk. I think there's definitely, the bone edema is going to tell you exactly how traumatic that injury was. And no doubt that has some influence on the underlying risk of OA development. You'll see bone contusions on MRI a year out, even longer sometimes. And so the ability for those to heal and restore likely is linked to how early they're going to develop OA. So I think that's certainly part of the equation. And when we're thinking about OA, there's no way it's just mechanics, right? I will never say that you can just restore normal loading and you're going to solve their OA risk. There's a lot of biological underpinnings that's going to go into risk. So I think that's certainly part of the equation, and unfortunately something we don't have a lot of control over in terms of the risk.
How about the other factors, range of motion, gait, strength after a bone contusion? Any specific insight?
I mean, I don't think I'll jump in. I don't think we have a whole lot to guide, how you should differentially rehab someone that has a worse bone contusion. But I mean, again, I think you're just relying on patient response and tolerance while still trying to achieve the same benchmarks, but knowing that, whether it's bone contusion or cartilage injury or cartilage defect, acutely, that they may require more time, that, rehab may be a little slower. I think these are things that you might consider.
And I think clinically you're using effusion, you're using knee soreness to guide you in those things. Those are going to move along with the severity of the injury and other things going on within the joint. And so I think from a clinical perspective, that's probably the more important thing to rely on, is just tracking effusion and soreness to guide how you're progressing those things.
Okay. All right, let's get into some strength here. A question about the NMES usage. So I've seen protocols that call for 5 hours a day early on, but the systematic reviews, at least I saw in your talk, Liz, there's a big variability. So like is there an ideal protocol and optimal dosage?
Stephen probably has more to add to this, but I think it's incredibly unrealistic that anyone's going to do 5 hours a day of it.
Yeah.
We do 15 minutes of NMES, 2 to 3 times a week. And, we use it just as an adjunct to the other strengthening that we're doing.
Yeah, we're about the same. I think it was interesting. I watched Liz's presentation. She made a good point. I think we get rid of it too soon. Like, and I'm guilty of this. Like, it's probably something that needs to hang around a little bit longer. I think maybe because it's just the setup and everything is kind of like cumbersome. Now you start putting that on top of like a BFR unit and you're just like trying to figure it all out. But we're usually, I would say at least 6 weeks we're using NMES, sometimes shorter for our quad stuff. But some of these kids, like the kid I had, like he just didn't need it. Like he looked great without it. I mean, NMES wasn't helping him get his quad. It was already there. So It's kind of patient specific too, right?
That 80% threshold for discontinuing it, is that supported by evidence, or is that more of a clinical recommendation?
I'd say probably more clinical.
As far as I know, it's clinical.
Yeah.
Yeah, I agree. And I think sometimes if they're just having a hard time, they kind of plateau out at 80%, and you get rid of them NMES and they just plateau out and they don't keep improving. I don't think there's anything wrong with going back to some NMES and trying to get them over that hump and up to where you want them long term. So I don't think you have to completely rule it out. There's no harm in using it after they get to 80% either. It's not that magical number that you have to get rid of it. There can still be some good use for it.
Yeah, and I think to that point of bringing it back, you have someone who, let's say, starts to develop some patellofemoral pain or issues, and they're having, they get into a loading pattern where they are, kind of becoming more quad avoidant, and what I've seen is that sometimes it can help to kind of kickstart the quad again and, make it a little easier to strengthen and walk that line between getting stronger without irritating the knee. That's another example. Another point that I would make for NMES is, and I think most everyone is doing this, but assuring that the stimulus that you're using is actually doing what you want it to do. So I think, having or using NMES in a way that isn't causing full muscle contraction probably isn't doing what we want it to do.
It's not supposed to be fun, is what you're saying.
Right.
Okay. All right. Okay. Well, here I have here's a kind of a clinical biomechanical question here. Is there a way to pick up hip and knee squat ratios without dual force plates? I'm going to ask Susan Sigward the same question later.
Not right now. Technology, and you can't pick it up even with dual force plates. You can pick up ground reaction force. You can pick up how much weight they're putting through each limb with your dual force plate setup. No different than putting a couple bathroom scales underneath of each foot and seeing how much load they're putting through each limb globally. But they can move. You can watch them and they can be moving extremely symmetrically from what you can eyeball, and they will still be fooling you and have this compensation within the injured limb of shifting load to their hip and the glutes. And you just can't pick that up without kind of a motion capture setup. Now there is some markerless solutions coming out that I think is going to move what we're doing with motion capture into a more clinically feasible space and setup where it's not as time intensive and is a quick thing to do. So I think down the road we might have the capability to do that clinically a little bit more. But yeah, you can't catch that with even 2 force plates in a clinic right now.
So what's my best bet then? I'm a clinician with minimal resources. I have a smartphone, but I don't even have force plates. What bang for your buck? It's going to give you the most reliable kind of read on someone's movement quality.
Yeah, I'll chime in just to say that, I mean, for sure, using some form of video is going to be better than just watching it with your naked eye. Okay. Now, are there data to support that? Maybe. I don't know. But at least having some way to attempt to measure and capture movement patterns is better than watching it in real time and in real speed. And I think, if we're talking about kinetic or load-based asymmetries versus kinematic or shifting joint load, we see this varies based on the task type. So, if somebody's doing something with 2 legs, there's easy ability to shift and offload their surgical limb. That is hard to see, particularly when it's subtle. Some of the kinematic adaptations that we see, like shifting into the hip, using the glutes, flexing the hip, more. Sometimes, depending on how much that's occurring, it's a little easier to see. You can kind of watch the trunk as a good indicator at times. So if they do tend to, flex the trunk a lot more, it's easier to catch. Even if they are sufficiently flexing their knee, shifting their load or their ground reaction force back or forward, off of the knee. So those are just some general thoughts. There are a lot of motion capture 2D video apps that are out there that, again, I think are going to be better than just watching it in real time. Using something to measure or quantify movement is good.
I agree. And it's my opinion that you can see some of those deficits more easily in a faster movement, like a drop jump, or even looking at the quality of a single-legged hop compared to a slower squat where they can move more visually symmetrically, I think. And I guess I'm not trying to say that sometimes you won't see differences even with a squat. You will, but if they don't have full quad strength and they look like they're squatting symmetrically, I would almost guarantee that if you did a more in-depth analysis that they're not squatting symmetrically. You can't do it without full quad strength. Dr. Sigward has shown that. We have some similar data. So I would argue that until you have full quad strength, they're going to fool you if they look like they're moving symmetrically, because I don't think they're loading symmetrically between their hip and their knee if they don't have full quad strength. So, but I do think that doing faster movements you see more of those trunk shifting the hip more, that you might catch more during faster speed movements with some 2D analysis.
I mean, Stephen, you guys have force plates in your clinic. Are you using them with every ACL patient?
Not right now. I have it's called a balance mat. Put it away when we did some moving. I need to pull it back out, but I don't remember. I don't pay for it. Somebody left it here. It was one of those, hey, try this, and they never came and picked it up. But it was pretty cool. It connected. It was wireless to the computer, and you could see on their squat, like, were they loading each leg appropriately. But I think even if you don't have those, like, I think it's safe to assume, especially in the early phase, like, I'll ask my patients, like, hey, does that feel 50-50 to you? Like, when you're squatting, do you feel 50-50? I'm like, cool, you're not, but I want you to be actually like a 60-40. So I want you to feel like you're doing more load on your surgical leg than your non-surgical leg. And I'll start that at like week 3-4, we start squatting, put them in front of a mirror. Mirrors are great feedback, right? Like, they have a mirror at home, get in front of the mirror, but understand that I want you to feel like you're overloading your surgical leg more than you are your non-surgical leg.
And we also give them the cue to try to kind of center the weight under their foot in a similar place to their uninjured side. Because as you shift that weight distribution either towards your heels or towards your toes, you're going to change how you're loading your knee. So I think that's another cue that you can give them, is tell them to try to put the weight under the same part of their foot as their other side.
Oh, that's great. All right. Well, then here's a question about gait. How are you assessing gait clinically, and then how do you try to make changes? We know that gait is significant, and it's significantly changed and can have long-term impacts. What are you doing in the clinic, and how do you cue people appropriately?
Yeah, clinically, it's just, we were lucky to have a huge space, so we have a track, but it's just a visual thing. I will record sometimes because I think a lot of it, their perception isn't reality. I think one of the lectures that was done actually kind of talked about that, but like what the patient feels is not what's actually happening. So you can kind of record them and show them, and then they're like, oh, wow, man, I didn't even know that I was doing that. I found some great value. We have a curved echo treadmill. I think the curved treadmills are really nice for like replicating a natural kind of walking and a running pattern. So we've used that quite a bit, but just a lot of like visual feedback, like get them in front of the mirror, hurdle step overs, and just tons and tons of repetition until they feel comfortable with it and it looks better.
I hope that's something down the road with more wearables, that we might have better ways to actually kind of objectively measure and evaluate gait. I think that might be something down the road, but we're just not quite there yet in terms of understanding what's important regarding all the new wearable technology.
When you say wearables, like, where do you see that going in the future? Like maybe like foot pods on each shoe that give some information about accelerometry or something?
Yeah, it might include, I mean, you can get different inserts to even look at amount of load through each limb. Certainly looking at IMUs and accelerometers that, measure velocity and speed between limbs and how fast they're accelerating and decelerating at the beginning of each step might start to provide some useful information and possibly get to the point where you're getting real-time, kind of a visual feedback of that maybe you could start to implement when they're on a treadmill to try to match the same velocity of movement between limbs. That's where I see some of that stuff going down the road, because it has to be able to give some feedback back to the patient. Otherwise, it's not going to be useful.
Yeah, in particular, immediate feedback, and something that is clinically accessible, easy to set up, no processing time. It's right there. You get it immediately. And I know there are groups that are working on this. I actually was meeting with a couple of undergrad biomedical engineering students that were kind of trying to develop something like this a couple of months ago, where it's, there are two devices that are worn so that you can get information on bilateral, gait parameters and data. And they're trying to build it in a way that is kind of focused toward biofeedback, which might be pretty cool.
I'm going to they're doing on that in the next Q&A session too.
Sorry, go ahead and say that again.
I was just going to say, I'm sure Susan will have more to say on that in the next Q&A session as well. She's doing a lot of work in that space.
Okay. Well, I was going to say, I've seen, they you can download an app and I won't say the name of the company, but you hold it to your chest and it measures postural sway. And I know that they're at least have done this with Parkinson's patients. I remember going to Faye Horak's lab at OHSU PT school, and they were talking about using smartphones for that. It doesn't seem very far-fetched that you could, put an accelerometer in a piece of plastic and tie it to your leg. So I don't know. Technology-wise, it doesn't seem like easy for me to say. I'm not an engineer, but
yeah, there's things like that out there already. A simple IMU and a strap that you put around the thigh or the lower leg, like those things are out there. I just don't think we fully understand what parameters with them are important in terms of restoring gait and being able to use them to improve gait. I don't think we know enough about it and understand it. The technology is there, no doubt. Just the development of how we use that clinically, I think will come in the future years.
All right. Let's see here. Let me ask you, I saw someone pop up on the screen. I think it was, I think Dustin was trying to join and then he's gone now. Maybe we'll see if he can join the second session.
He's having some trouble getting in. We get blocked children by having some stuff, so we're having to find some way around it. So.
Oh, wait. Let's see if we can add him here. All right, I see him. Let me let's get out. Hey, hello there.
There he is.
Hey there.
Hey, Dustin. Well, we're live right now. You want to answer some questions about ACL surgery?
Yeah, I'm getting spotty service.
All right. Well, why don't you let us know when your service is coming in?
Do it. And I got
to
stay
try
in motion or.
Okay. All right. Well, let's start with the first surgical question here. Is there any current data on re-tear rates with internal brace augmentation?
So the historical data has shown when we're using that, it's typically with a soft tissue graft, a hamstring or quad tendon. Historical data has shown inferior results with soft tissue compared to patellar tendon, but the most recent results with internal brace compared to BTBs have been pretty much the same. And so I think it's very promising. I do it on every one of mine that's not very skeletally mature. So and currently they've made the techniques and the implants a lot easier to use. So it's almost a no-brainer to use it. There's not really much of a downside to it. So I'm a big fan of it, and it hasn't been out that long, so there's not a lot of long-term studies, but short-term, it's shown to be the same or better than a BTB without augmentation, and definitely better than soft tissue without augmentation.
Does anyone else have a comment on internal bracing? All right. So here's a question about here's another surgical question. So with boys maturing or growing later than 15 plus, is the criteria for choices in ACL surgical intervention based on growth plate status or chronology only? Catch that?
No, let me go ahead. I'm on my Wi-Fi now.
All right. So with boys maturing and growing later than 15 plus, is the criteria for choices in ACL surgical intervention based on growth plate status or chronology? And he's gone. Okay. All right. I don't think these ever go as planned. All right. Does anyone have any comments on growth plate status and ACL surgical technique?
I mean, I'll jump in to say that I think a lot of these, fascial sparing procedures we're learning more and more about them. Historically there was, I'll let Dustin chime in. He's going to know more about this than me.
Sorry, Matt, ask the question one more time. I caught the first part.
Okay. Question here is, with boys maturing and growing later than 15 plus, is criteria for choices in ACL surgical intervention based on growth plate status or chronology?
Definitely not chronology. It's going to be more on the growth plate status and the overall maturity of the kid. We don't, Tanner staging's a pediatrician thing. It's not really appropriate in the orthopedic setting, but the nice thing is we can push the limits a little bit, because when we're putting soft tissue with a small footprint across the growth plate, the risk is pretty minimal. There's some studies out of Emory where they're actually doing transphyseal or drilling across the growth plate as early as 9 and 10 years. I'm not in that camp completely, but there's some 16-year-old boys that are skeletally immature enough that I would not feel comfortable doing a BTB on. Then there's some 12 and 13-year-old boys that absolutely have no issue with it. So, and I think the plain X-rays, at least to me, are the most reliable. It's hard to tell much on the MRI, and so when patients say I already have an MRI, I don't want X-rays, I think it is important, especially in these younger kids. So chronology is not very reliable. Same with the females as well. It's more of a physiologic age that we go by.
Okay. Matt, you want to finish your thought?
No, not really.
Okay.
Well, yeah, I can kind of throw the question back to Dustin, or rephrase it. Your thoughts on fascial sparing procedures versus, I mean, you kind of just indicated that there is some gray area in those that are maybe still skeletally immature, but not, they still fall into a category where you may do drilling across the growth plate. So I was just curious about that decision-making paradigm, what markers you're looking at specifically to make that decision and so forth.
I mean, it's weird for such a important decision to come down to just kind of an overall feel of what do the X-rays look like, what does the kid look like, and even sometimes if you're really in between, Tanner staging obviously involves genitalia and puberty and things like that. Sometimes I'll be in between a going physeal sparing or allopephyseal on the femur, which is a slightly non-anatomic versus a regular transphyseal. And kind of a last second Tanner staging might assist in how I make that last decision, but I have all the guides there anyway, so it's not much. The tibia tunnel, when you drill it, it's relatively, find my hand on the screen, vertical. So the footprint is about the size of the drill bit, which in these cases is 8-9 millimeters and pretty small. When you're drilling oblique on a femur, that actual footprint through the growth plate can be pretty wide, especially with our current anatomic placement. And so I'll rarely go allopephyseal on the tibia, and I do strongly consider staying in the growth plate on the femur. It's not too difficult, and it's just one less thing to have to be concerned about going forward. And I follow them all to skeletal maturity too. So I haven't had any issues, but I'm fairly careful with where I'm drilling.
Okay. All right. Well, then here is a question. This is more of a question about how to conduct. This PT wants to know how to conduct him or herself. It says 7 out of 8 docs in our town in one practice are doing peroneal tendon allografts. One is doing hamstring autografts. I'm a PT. Can you make some recommendations about having a conversation without offending the surgeons?
The data is so anti-allograft on adolescents that it borders on malpractice.
That might offend them.
Oh no, yeah, but I think you could reference a study, and I don't know. In the end, I mean, I've worked with guys that have been doing allografts at Miami Children's for a decade, and like their data's good. It's not, they're not having this 8 times re-tear rate. I think part of the data is probably skewed by surgeons that don't do a whole lot of them, and that aren't used to graft harvest and graft prep. About to lose this baby again, but I think just mentioning the data, or maybe asking them politely how they make their graft choice decision making. I've never even heard of using a peroneal tendon allograft personally, but I guess anything can work. But if it's an older patient population, the surgeon likes the technique and the results are good, I don't have any major problem with it. I know some very talented sports surgeons that take care of mostly, 40 and above, and they almost never do an autograft. I think I might still do it, but I'm a little bit biased, so I don't think the results are fine. I don't think there's much issue with it, but I agree it's a kind of a hard subject to breach, because in the end it's a decision between the patient and physician. But in a young kid, if they're doing a lot in your town, I think that's probably not ideal.
Anyone else have any advice for this PT?
I mean, I would, if it were me and someone asked an honest question of how do you make this, what's your decision tree with this treatment, I think I'd be happy to have that discussion. I wouldn't be overall offensive in any way, and they may just say, hey, I've been doing these for 20 years and I have a 4% re-tear rate and patients do fine, there's no graft site morbidity, then might be a reasonable option in their hands.
Yeah, I think you're always better off just asking to understand how they go about those decisions, whether you're talking to a surgeon or a PT or anybody, just asking to understand kind of their reasoning behind those things. And I think that's going to be the best approach to open up those conversations, at least.
Okay. So don't shout them down on Twitter. That's not the first step.
All right. Reinforcements have arrived. Silence.
All right. Excellent. All right. Well, let's, here, I have a question. This is, Liz, you did a really great job addressing this in your talk about open chain extension exercises. And I think this is probably the myth that won't die. I don't know that it ever will. And so someone asked a question about it. So do you think leg extensions without load can be introduced early, taking into account partial range, using external load or maybe just manual resistance? Like, what's your thought process on knee extensions for, after ACL reconstruction? And I would love to hear from the surgeon as well about what your take is and thought process is on, open chain knee extensions after reconstruction. So maybe Liz, would you mind just starting us off and just talking about what you kind of touching on what you presented on it?
Yeah, I can start. I think if you're thinking about asking someone to walk with a normal gait pattern, you're asking them to go into terminal knee extension, right? Against gravity. So if you're asking them to walk like that, there's no reason you can't introduce that early. You're not going to put a lot of load on them early, but you can start introducing that and teaching their quad that it's okay to move their knee in that way and to get their quad to fire in that range. So I think there's no reason you can't introduce it early, and there's good data to suggest that you're not going to strain the ACL anymore doing that than you do during a normal gait pattern, and if anything less. So maybe start that to get the conversation going.
Yeah, I had a question on this patient, kind of a gym rat dad, wanted to get his kid in the gym. They were very compliant with PT. Kid looked amazing at like 3 or 4 weeks. They were doing all the right thing. It's just the overeager parent had the question about knee extensions. And again, with no major data, I'm more just thinking about the mechanics of knee extension, and that I don't have a major issue. It's kind of, at least in my head, reducing the rather than putting tension on it. So I told him just keep the reps like at 20, 30 and just super light. If not, just no weight at all. Just moving the pin on the machine up and down for some repetition. I didn't have any major problem with it, but made it pretty clear that it's not the time to start increasing weight or anything like that. So I don't have a major problem with it personally.
What are you doing in the clinic, Stephen? How are you progressing people through that early post-op open chain?
Yeah.
What's your process like?
Initially, it was the 90-40, right? The long arc quad 90-40. I made sure they had like isometric. They could isometrically push into me with good control. For like probably, I'd start that as early as week 1, week 2. But most of mine by end of week 2, week 3 have active long arc, maybe not full. I've now moved on to like a little bit of a short arc quad pretty early on with the NMES and the BFR. So I'll put a little towel roll underneath the knee and have them squeeze into it for some feedback. And I'm not upset at all if their heel lifts off the table. It doesn't bother me one bit. I'm not loading it up. And I think the beauty of the BFR is that we don't have to load it up if we're really worried about it. We're still going to get some really good activity and some muscle contraction and some growth from that. So I'm not afraid of it. I've never not done it. I can't remember a time when I was never doing open chain knee extension.
Do you think the myth will ever die?
It's like the guy doing perineal allografts. Like, you're going to have people that aren't going to, budge on what they believe. And, well, this paper was out there in the 70s and it was, I still just, they're comfortable with that, right? I think most of us will get away from that mindset. I think a lot of us in my clinic, none of my therapists follow that mindset of closed chain only. We all do open chain stuff. So I think it'll probably eventually get better. It may not be complete, but I think we'll get through it.
All right. There's a question about pediatric going non-op. Are there any? Is there any research showing non-operative care for pediatric ACL injuries?
No, there's a lot of research, but pretty much all of it favors surgery, favors a stable knee versus continue just not playing sports, which that's a terrible option for a kid in general, but sometimes kids do it accidentally and weren't playing sports in the first place. And to the parents, a knee surgery with open growth plates versus just not playing competitive sports sounds like a reasonable option. The problem is it's been shown that there's still instability with daily activities and the risks. There's studies now. Because that was a common treatment not that long ago, and it still is in most smaller towns. We get a lot of second opinions from West Texas, Oklahoma, everywhere, where they were told they didn't need surgery, but the family researches, and it sounds like that's something that's available. So it's still a very widely practiced, first do no harm. So I think doing a surgery you're not experienced with around growth plates is a little dicey. So I don't blame people for personally not wanting to operate on them. But there has not been a study that's shown that it has been equivalent waiting until skeletal maturity or later. All the outcomes are worse, whether you measure recent outcomes with meaning risk of meniscus tear, risk of cartilage injury in the short term. But there's 30+ year studies that show the risk of arthritis is substantial in kids with delayed ACL reconstruction. And it's pretty minimally invasive now, so it's not a major disfiguring surgery that it might have been 20, 30 years ago. So, but yeah, non-op is not the right answer in a complete ACL tear in a kid. But again, it's not, this isn't cancer. It's not gonna, and so I don't make people have ACL surgery on their kid necessarily, but I think it's worth mentioning that your kid's going to look fine for the next few years, but the arthritis can start catching up with them pretty early in the next 10, 15 years for sure.
Liz, you probably know this. What's the Coper, the age range? When does that start becoming relevant?
I don't think age really plays into whether or not they're coping well with the injury or not. That's going to be a differential response across age. So I think it's always relevant in terms of how they respond, especially neuromuscularly, to the injury. Some are going to respond really well and some aren't. Just like Dustin said, some young kids will tear, some older middle-aged adults will tear and they'll not even know and respond really well. And others, it's, severe impairment right after injury. So that kind of differential response certainly can occur across and irrespective of age.
Mm-hmm. Well, you guys have answered pretty much all of the questions that I have. And I feel like that's kind of a downer note to end on. Does anyone have any anything, any good news to end on? Any last thoughts or comments or anything maybe that we didn't cover that you wanted to touch on?
Well, Matt, one question I was going to actually ask Dustin, since
Sure.
he's on it wasn't in the question pool, but I was curious your thoughts on, the kind of big hot topic thing right now that's talked about a lot is the Bear procedure. I was curious your thoughts on it. I know they've published recently published some 2-year data from that procedure.
Yeah, so ACL repairs have a bad reputation because historically the older studies with horrific results were open procedures as pre-arthroscopy. They were just putting stitches in whatever was left of it, and of course they didn't do very well. They were casting them for weeks after they did an open knee surgery on them, so everybody did terrible. But we, more recently with new fixation devices, people have been looking at, we take a torn rotator cuff that's ripped off the bone. Why can't we sew our ACL back down where it came from? We started to repair our ulnar collateral ligaments. Why can't we repair an ACL? And so the newer techniques have been pretty good in terms of fixation. The results are still not as good as ACL reconstruction, but it's less of a procedure, and the revision procedure is actually a primary ACL. So there's a lot of reasons it's positive. The Bear procedure, just some disclaimers on it. Number one, it's FDA approved recently, it's the first FDA approved device specifically for ACL. I forget how they market it. That basically says that the collagen sponge has there's no complications from adding a collagen sponge, resorbing collagen sponge in the knee. This has been proven to work and is a great procedure. It's just that there's no danger to using the sponge. And what they do is they repair the ACL, put this collagen sponge, and are able to put whatever PRP stem cells in it which all sounds pretty positive. The other caveat with their results that are actually pretty good, they use an internal brace, so they repair it, but they also put a fairly unbreakable suture through drill tunnels, fix it with a button on either side, and so they're essentially putting almost a equivalent of an ACL in there at the time they're doing this repair procedures. So I think there's a little bit of skewed data, but and I think the general principles that have been with ACL repair and recently should still be important. Like the tear needs to be proximal to the bone. You can't repair a mid-substance. It's just not. It's not going to heal. They might do okay because you put an internal brace in there and that'll kind of hold the knee together good enough until something happens. But so I think it's a good concept, but I think the marketing may be better than the actual results. But I have had more than one family come in asking specifically about it and that had the data. So I think you just have to look into it a little bit further. But an interesting concept. I think ACL repair is kind of coming back. I don't do a ton. I'm just a little nervous because most of our kids tore their ACL playing high level sports. So I'm a little nervous till there's longer term data. And I think the longer the data comes out, it's slightly less promising than it was maybe 3 or 4 years ago when it became popular again.
I'll jump in with a question for Steven. A lot of times we have kids that come in that just are coming in for testing. And when we look at their quad strength, especially with like 13, 14, 15-year-old boys, their quad strength, both sides just keep going up and up, right? But their deficit inner limb remains same. Like they're, 20, 30% because both sides keep getting stronger. What approach do you take with those kids that are spending 9 or 12 months with you? They're going to get stronger, right? They're a 14-year-old boy. They're ready to get stronger. Do you push contralateral strengthening early, or do you get them symmetric first and then push bilateral strengthening?
Yeah, we see that so much. We actually call it like chasing the rabbit. Like we do those biotech stuff. You just can't catch up. And it's even worse. Like if you've ever tested professional athletes, it's even worse. So those guys can push like 300 foot-pounds of torque on their non-surgical leg. Like, I don't know any way to get to that point with loading. I think a lot of this is neurological. I think some of this is just like time, but we train everything initially bilaterally, and then we switch to like an asymmetrical load and a single leg. But what we'll do, especially in our performance center at Exos, is we may add an extra rep of 8 to the surgical side. But another way to kind of combat that is definitely some eccentrics and then also more time under tension on that surgical side when they're holding their load. So like a lot more tempo based stuff. Maybe instead of like a 3-second hold, they may hold it for like a 5 or 6. And I think that's kind of getting us a little bit more into kind of a symmetrical pattern for their strength, especially for their quads.
Cool.
Yeah, it's definitely something I've seen my entire career. It's a battle. But yeah, I'm really like heavy on the eccentrics right now. Especially for these, I have a couple kids that we have killed them in the clinic in rehab and performance, and they're testing at like 50% deficits at 9 months. And I know they're putting the work in. I know they're loading, but they're just not getting the response to the muscle. And I don't remember whose presentation talked about that, but I think there's some tremendous value. It may have been yours, Liz, about the eccentric component to strength training, kind of getting around some of that.
Steven and everybody else too, I'm curious. So I was at a team physician meeting with most of the pro team docs, and we were talking about ACLs and graft choice, and I was shocked the amount of just BTB gurus from the last few decades that are really getting converted to quads, and more than one NFL physician who was mostly exclusive BTB in the past few years had switched to quad for everybody but NFL players, not because they weren't good enough for NFL players, but just a little stigma of the NFL and BTB. So I'm wondering if anyone has any. We're starting to do a little bit more practice. We haven't had the issue of hamstrings re-tearing and diameter issues or anything like that, but I'm curious if anyone has any early experience with quads that they've been impressed with them, or they seem the same or better, worse. Any thoughts?
Yeah, I haven't done enough of them yet, Dustin. I know we just started doing them down here. It was a big topic at Prism 2 years ago, was the quad tendon, especially in the youth population or the skeletally immature kid. And there's some good data on it. I mean, those guys are pumping out. I mean, our buddy up there in Seattle, they've got some good stuff coming out of it. I'd like to see more. I can't really make a comment. I haven't seen enough of them personally, but the research is relatively promising.
Yeah, I agree with Stephen. I haven't seen enough of them to have a strong, opinion or conclusion clinically. Some of the surgeons around here that I talk to about them are a little down on them in that they're saying, we'll see what the longer term data and outcomes look like, but you're disrupting the extensor mechanism while also not having the benefit of bone to bone healing in the tunnels. At least in my clinical experience, I haven't seen a big noticeable, difference or improvement in return of quad function strength compared to others, and it's pretty similar in the few that I've seen. So it will be interesting to see. I mean, I know there are some groups that swear by them that do a lot and rehab a lot of them, that think that they're that they're great.
Yeah, we're just starting to see that transition a little bit. A few more quad tendons have been popping up, I'd say, over the last year or so. Like the people that were doing hamstrings are moving towards patellar tendon, and the surgeons doing patellar tendons traditionally are kind of starting to toy with quad tendons. So, I think more to come. We just don't have long-term data on those quad tendons.
Yeah, I know we're not plastic surgeons by any stretch, but the footprint left behind from a BTB, especially on a thin female cheerleader, like, it's pretty gnarly scar. It's a pretty barbaric operation that we're doing. Some of our second looks where we're operating for either a revision or meniscus tear, like, man, that knee's not as nice as it looked when I was in there the first time. And maybe the soft tissue is not changing that a whole lot, but just the minimally invasive nature, as long as the data catches up with BTBs and stays superior, and the addition of the internal brace and all that, I think it might be the way everything goes in the future. And if you get a chance to kind of compare the patellar tendon to a quad tendon on an MRI scan, just kind of flip through it, you're like, dang, that thing is big. And we don't even blink at taking a third of the patellar tendon in someone. But then you see that quad up there, you're like, okay, like, it makes you a little nervous in theory till you see it on a scan in 3D. You're like, okay, that's pretty dang big thing, and especially when you compare it just below the kneecap to the patellar tendon. So I think it's just only going to keep catching on, and we're starting to do more, not because our hamstrings suck. We're really happy with the way we prepare our graft more than anything, so we get good graft size. But almost like I'm scared of getting left behind as the last guy to do quads. So, and they've been good too. And when you see a quad post-op, especially with the new harvesting techniques, like it is, you're like, how, in hindsight, especially with the knee extended, and you see those tiny incisions, you're like, dang, it's crazy. We were able to do a 9-10 millimeter quad tendon graft through these tiny incisions. So I like it so far. I'd say I'm definitely on the inexperienced in terms of total numbers, but we got a couple coming in next week, so I look forward to keep doing it. I think it's only going to grow.
Yeah, at least from the few that I've seen come through over the last year or so, they certainly don't seem to deal with as much anterior knee pain as the patellar tendons. So that's certainly a clinical perk in terms of not hitting a road bump in your quad progression post-operatively. They seem to not deal with that quite as severely. Sometimes still there, but doesn't seem to be quite as severe.
Yeah, I do agree with that, Liz.
All right. Well, we are just about out of time. I really appreciate all of you joining me on your Saturday morning, giving up some of your personal time for this. I appreciate it. We got it's had a really great conversation. I learned a ton. I have more questions, but I really appreciate you all taking time to be with me and with us here. We have a patient session coming up next in about 15 minutes. So if anyone is watching, I would love for you to join that as well. That's going to be moderated by Jordan Angeli and 5 real patients who have been through this surgery, some more than once. So if you can join, that would be great. And then again, we have Doctors Susan Sigward, Dustin Grooms, and Julie Ibensteiner at 11. So, all right, well, that's it. Thanks, everybody.
Thanks.